Yeah, just
Recording is started, I guess.
Yeah, it started, I think.
yeah.
We
So
got a message.
almost yes, sir. So welcome, very good evening to all our participant delegates, our esteemed speaker, moderator, and today is our 39th episode of Apollo Mumbai Critical Care Learning Network. And I welcome you all to this very interesting session on advanced lung ultrasound. As you know, already sir has taken our esteemed speaker, Dr. Kedar Toraskar sir has taken already a part on basic lung ultrasound. So to carry it further forward, and today he is going to speak and demonstrate us all the tricks and tips regarding the advanced application of lung ultrasound for intensivist and critical care specialist. So without making it further delay, I welcome sir. And before he start, I just like my co-moderator, Dr. Akhilesh, to have a brief introduction about the speaker and the moderator. Thank you.
Yeah, thank you, Dr. Gunadhar. It's indeed a great pleasure to invite Dr. Kedar Toraskar. He's head of the Department of Intensive Care at Wockhardt Hospital, South Mumbai, and he has done extraordinary, work on lung ultrasound. Means it is his tool. Lung ultrasound. Ultrasound itself is his tool for hemodynamic monitoring, and various innovations have also been seen with his clinical approach. And last time we had a discussion on basics in ultrasound, especially lung ultrasound. This time we are going to discuss on a topic called advanced applications of lung ultrasound. So welcome, sir, today for this wonderful session, and I hope these students will be benefited at large. With this, I have my co-moderator, Dr. Gunadhar Padi. He is head of the Department of Intensive Care Medicine at Apollo Hospital, Navi Mumbai. And my co-moderator is Dr. Subhadeep Sen. He is also consultant and intensivist at Apollo Hospital, Navi Mumbai. Over to you, Dr. Kedar Toraskar, sir. We can start the session now. Thank you very much.
Yeah, thanks Akhilesh, thanks Gunadhar and Swardeep. So it's a pleasure to be back on this forum, and today I'll be talking about advanced applications of ultrasound, lung ultrasound. So can you all see the slides, and am I audible?
Yes.
Okay, fine.
We can see this.
So just a warning that advanced applications, you have to fortify your basics of lung ultrasound and focus. So no advanced applications will help you if you don't get your basics right, and that holds true in all the fields in medicine or wherever you are. Okay, so that's the basic concept. So as students, we try to we want to know more and more about advanced things because that is fascinating, and we feel that once we know the advanced stuff, we are done and dusted. But no, it's the other way around. You should hone your basics. You should fortify your basics properly, and only when your basics are fortified, then go to the advanced application. Otherwise, these advanced applications are of no use. And in medicine, most of the times, if your basics are right, you can handle any situation, whether it is critical care or whether it is general medicine or any field for that matter. So lung ultrasound is an integral part of whole body ultrasound. So there is obviously a paradigm shift now. So what is the paradigm shift? A paradigm shift is sorry. So these are some clinical applications of lung ultrasound. As I told you, the paradigm shift is towards the whole body ultrasound rather than a single organ ultrasound. So just lung ultrasound is not enough. You have to include a whole body ultrasound. And if you see the clinical applications of lung ultrasound, it includes everything. So what are the advantages? Avoid referral to the CT scan. So limit radiation because of the CT, limit transportation risk, limit bedside radiographies, decrease the radiation dose. You get safe thoracocentesis or procedures which are ultrasound guided. So nowadays in ICU, all the procedures should be ultrasound guided, and the ultrasound makes procedures safer. Okay, and they are more successful as compared to the blind approaches or the other approaches. Obviously, pneumothorax, pulmonary edema, embolism, trauma, cardiac arrest, dyspnea, you name it, and we have it. So it's a bedside technique. It's dynamic, it's non-invasive, safe, it's reliable, it's time-sparing, it has a high feasibility, easy to learn, it's repeatable, it's cost-effective, and guides therapeutic procedures, as I just said. And it's obviously also suitable out of the hospital in emergency setups also. It has been used on the war fronts also. So what are the drawbacks? Obviously, if you have subcutaneous emphysema and surface layer thickness or pleural calcification, or you have dressings or wounds or drains in post-operative patients, insonation becomes difficult. But obviously, these are not absolute problems. These are problems which you encounter once in a while. And obviously, accessibility to deep lesions, sometimes deep abscesses, adenopathies you can't access, and obviously the need for specific training. That's why we are here in this session now. So the paradigm shift, as I told you, is moving away from compartmentalization. Compartmentalization means that you just see the IVC diameter and collapsibility and decide about fluid. That's absolutely wrong. Okay, so don't don't compartmentalize yourself. It should be a whole body ultrasound approach. And obviously, this was propagated by the genius man, Dr. Daniel Lichtenstein, in 1993, and it is an appropriate amalgamation of ultrasound of vital organs depending on the clinical scenario. So the standard examinations in focus are lung, cardiac, pipes and vasculatures, the basic abdominal ultrasound, and other elements when used when clinically indicated. So we have various protocols for whole body ultrasound. It may be rush for undifferentiated shock, that is rapid ultrasound and shock and hypotension. It may be blue for dyspnea, which we'll be discussing in detail today. It will be false for fluid administration. False is fluid administration limited by lung ultrasound. Feel or CSUM for cardiac arrest, pink for fever, COVID-19 protocol, which I'll be discussing today, a trauma protocol, acute abdomen weaning protocol, again, which we'll be discussing today as a part of lung ultrasound, and of course, the neurology protocol. So just going back to a few of the basics so that it becomes easier for us to understand the, the, the lung ultrasound, the advanced techniques of lung ultrasound. So delineate which zone or blue point is scanned. So that's the first and foremost. Identify the bat sign first. So by identifying the bat sign, you know where the rib and the costal sector is. So your pleural line is below the costals, is below the bat sign. So skin and soft tissue sector, you have to identify whether there are any E lines or artifacts there. So whether you have subcutaneous emphysema. Then identify the pleural line, which is a pearly white structure which moves with respiration and which has characteristic of sliding, inherent sliding. That's your pleural line. And the next question is whether sliding is present or absent. The next question is whether your pleural line is regular or irregular and whether the pleura is thickened. The next question will be on the subpleural sector. So in the subpleural sector, you have A lines, B lines, or C lines, or a AB pattern. So whether it is an air interface or whether it is a tissue interface. If it is a tissue interface, it's a true image. Whether it is when it's an air interface, it is an artifactual image. So if it is an air interface, you have A lines, B lines, C lines, AB pattern, or a combination of all these. Then obviously identify the protocols based on the lines. So whether you have a protocol, A profile, or a B profile, or a B prime or B dash profile, or a C profile, or a AB pattern. Screen the heart and the IVC, as I told you, because we are not going to compartmentalize ourselves with just lung ultrasound. And obviously fit into a clinical syndrome. That is very, very important. Change the therapy as per the inputs of your lung ultrasound or your ultrasound aided diagnosis, and use history, clinical findings, biomarkers, and other diagnostic tools for the same. So this is very, very important. Your clinical ultrasound is not a substitute for your clinical examination. History is also very, very important. So the ultrasound findings become finer and you can pick up more details if your pre-test probability is good or if your diagnosis is good. And obviously use ultrasound to guide procedures to make them safe and more successful. So that's again one more advantage of ultrasound. Let's come to a case. 66-year-old male, known case of IHG, old ASMI, LVF of 40%, presented to the ED with sudden onset chest heaviness and dyspnea at rest around 20 minutes back. Also had fever with chills a day prior. On arrival was tachycardic, tachypneic, BP was 70, systolic, shock state. Orthopneic saturation was 82 on room air, again respiratory failure. ECG was showing sinus tachycardia with fresh anterior wall ST depression. He had a bradycardic arrest in the ED for which he was given CPR for around 8 minutes, after which ROSC was achieved. Unfortunately, the machine could not be got within 8 minutes. There was no machine there. So once we did the bedside ultrasound, immediately post ROSC, once the machine came up, we saw this. So this was a left upper blue point on the lung ultrasound. And what can you see here? So obviously this is the lung. That's your pleural line there. That's your pearly white hyperechoic structure is a pleural line. So that's your subcutaneous tissue. Okay. So that is showing E lines here. If you can see these lines, if you can observe very closely, there are vertical lines which are coming from the footprint here and going down right here. And you can see that here you can't see the bat because we have used a cardiac probe, but that's the rib artifact here, and that pleural line is not moving at all. So it's the sliding is absent, and you can see parallel horizontal lines, which are again the A lines. So here you have E lines, you have a pleural line which is not sliding, and you have a A profile. So it is called as a A line sign. And obviously, this patient had a pneumothorax, right apical pneumothorax there, and that's why this picture here. And when we put it on the M mode, you got a stratosphere sign here. So interestingly, we did the left LUS flaps. So on the left side itself, in the flaps region, okay, in the flaps insunation area or quadrant 4, we got this. So you can see this. This is very classical of what we call as dynamic air bronchogram. You can see those white hyperechoic structures going to and fro with respiration. And you can also see a shred sign here. You can see hyperechoic white dots in the consolidated lung. So that's the actual consolidated lung, and this is a dynamic air bronchogram, which is a hallmark of a pneumonia. So this patient's fever was explained by the dynamic air bronchograms in the left upper zone. So he had a apical pneumothorax and a right basal pneumonia here, and his cultures later on grew to be pneumococcus. Okay, he had pneumococcus in the blood. And interestingly, this was a right upper blue point on the right side, the upper blue point, that is quadrant 1, which showed a sliding which was present. You could see those E lines here also because the subacute had spread to the opposite side also. And these, you had a coalescing V lines here, so like a whiteout lung here. So this was an alveolar interstitial syndrome. Because of his poor LV function, he was in left ventricular failure also. And this was alveolar interstitial edema, that is cardiogenic pulmonary edema. And we insonated the heart also because you do a whole body ultrasound here, not just the lung. And you can see that the ejection fraction, it's a simple eyeballing technique. Even for a beginner, you can see that the heart is not moving that well. So you can see that by eyeballing, it's a severely reduced ejection fraction. And you can also see regional wall abnormalities in the anterior wall here. Okay, so again, this was a fresh infarct here, and he had those STT changes which explained that. And you can see one more picture here. That's the lung, which is again, that's the heart, sorry, which is again showing a poor ejection fraction. I think stuck here. 1 minute, I'm stuck here. I'll have to go back. Sorry for that delay. Can you see my screen? No.
Hmm.
1 minute. I'll have to reboot. I think I'll join back. There's some problem. Give me 2 minutes.
Yes, yes, no issues.
So access has been given to you.
Tayeb, I think sir has joined. Just make him a co-host.
So I have given the access to him. He can unmute and start the video. Co-host has access has been given to him.
Okay.
Can you unmute Dr. Kedar Toraskar and allow him to share the screen also, please? Can someone please allow Dr.
Yeah,
Toraskar
you have
to
not made him
share the
co-host
screen?
actually. He,
He's joined already actually. Sir, are you able to share the screen now?
Yeah, yeah. Can you hear me
Yeah.
now?
Yes, yes.
Yeah,
Very
sorry
much.
for the
No issue, sir. No
technical
issue.
problem.
No problem, sir.
Yeah. Can you see my screen?
Yes, yes. We can see the screen.
Let me check.
Any other issues, sir?
Yeah, no, it's not moving. In 1 minute. I think there's some problem. Let me check out. Give me 2 minutes.
Sure, sure. No problem.
so we are sorry for the technical glitch. Just we sorted. A few minutes.
Hello.
Hello, yes, sir.
Yeah, sorry for the trouble. I think there was some problem with my network also. So
No
can you
problem
see
at all, sir. Have you
my
settled
screen
now?
now? Or-
I'm not able to see the screen.
Yeah, 1 minute. I'll just share it.
Yes, yes. Now we can see the screen.
Yeah, okay. So I won't go on to the whole screen because there's some problem with my sharing. So I hope you can see the slides here.
Yes, yes, definitely. We can see the
Okay.
slides. Sure, no
So
problem.
this
Thank you.
was coming back. This was the first case which I discussed, and this is the parasternal short axis. Oops, trouble again. I don't know what's happening. It's getting hanged in between. Some connection to it.
Maybe some virus issue.
So is there any
Maybe.
way I can help to troubleshoot? If you want, you
Yeah.
can send me the
See what's-
email. I'll start the slides and you can just explain. And this is the way we can
Yeah.
do it.
Okay. Fine. Let me check out. This is not moving. Yeah. Can you see this? Can you see the slides?
Yes, yes, yes. You
Visible,
can
sir.
see the
Okay.
screen.
So this was the short axis mid pap view, and in which you can see that the heart was not moving at all. Ejection fraction was very poor, and obviously this slide shows that the IVC was distended, so non-collapsible, plethoric IVC. And so here we come to the blue protocol, which is bedside lung ultrasound in emergency, and this was originally originally uh, coined by Dr. Lichtenstein, and this was presented after almost 15 long years of wait by Dr. Daniel Lichtenstein. But this was a path-breaking protocol, and this was one of the first protocols in focus, that is point of care ultrasound. And it gave you a relevance of bedside ultrasound in emergency when you encounter a patient who is breathless. And if you can see the slide here, the protocol goes as this. So the first question to be asked is whether lung sliding is present or no. But before that, you have to examine the patient, okay, and get a history. And then the blue protocol is to be completed within 6 to 9 minutes. That's what Dr. Lichtenstein had originally described in CHEST 2008, as early as 2008. But he had devised this protocol almost 10 to 15 years prior to its publication. And so this is the protocol. The first question to be asked is whether sliding is present. If sliding is present, if you go on the left side, whether it is a B profile or a profile. Now, if you have a B profile like this, you have comets lying like this. It is more likely to be a cardiogenic pulmonary edema. So if you have comet tail artifacts or alveolar interstitial syndrome like this, it is a cardiogenic pulmonary edema. But if you have a protocol and sliding is present, then you go to the venous analysis. That means you have a dry lung. So you go to the venous analysis. If your veins are thrombosed, obviously it's DVT and pulmonary embolism here. But if your veins are free and you have a dry protocol, go to PLAPS. The PLAPS is posterolateral alveolo-pleural syndrome. That is nothing but a quadrant 4 or quadrant 5. And if you have pneumonia in that, you see a shred sign, or if you see a tissue-like sign, okay, then it is pneumonia. If the PLAPS is free and the veins are also free, it is asthma or COPD. So it's a chronic obstructive pulmonary disease, or it's asthma. So it's basically a null profile or a nude profile on the lung, also called as a non-AB, non-A, non-B profile. But you come to the right side, and if you mention that the sliding is abolished, and you have a lung point here, like in this, and a stratosphere sign, and the sliding is absent with the A-line protocol, it's obviously a pneumothorax here. The pneumothorax looks something like this. So this is the stratosphere sign on the M mode, and you can see that it's a motionless lung, absent sliding, but a profile. So that's a pneumothorax here. So going forward, so if the sliding is absent without a lung point, then it becomes difficult. Then you have to maybe get a different imaging, a CT or something else to help yourself. So this is the blue protocol, lung ultrasound and diagnosis of acute respiratory failure. And you see the sensitivity specificity. For asthma COPD, you have predominantly A lines with lung sliding and a normal venous analysis. The sensitivity is almost 89%, specificity is 97%. For cardiogenic pulmonary edema, the sensitivity specificity is 97%, 95 to 97%. For embolism, you'll get a normal lung ultrasound plus DVT, and you may or may not get a Maconard sign. The sensitivity is 81%, but specificity is as good as 99%. For a pneumothorax, the sensitivity is 81%, but specificity is 100% if you get a lung point. A negative predictive value for pneumothorax is also good. So if you have B lines, then it's 100% negative predictive value for a pneumothorax. Or if you have a wet lung, if you have a sliding which is present, then obviously it has 100% negative predictive value for a pneumothorax in that quadrant. Okay, it may be a loculated pneumothorax anywhere else, but in that quadrant, if you have sliding present, then it's 100% negative predictive value for a pneumothorax. And of course, pneumonia, you have a prominent unilateral B line or abolished sliding and alveolar consolidation. You get a dynamic air bronchogram, as we saw. It has a dynamic air bronchogram has a 100% negative predictive value for anything else but a consolidation, a bacterial infectious consolidation, not bacterial. And the sensitivity specificity is again 89% and specificity is 94%. So that's pretty good. Now, this is one more multifocus lung ultrasound which was propagated by WinFocus. So here it is slightly different from the blue protocol. So it differentiates the air interface and a fluid interface. Now, what do you mean by air interface? Air interface is you have artifactual ultrasound. So if you have air in the lung, it may be normal air or a completely normally healthy aerated lung, okay, in which you have sliding present, but A lines which are present. Or you may have no sliding, that means, and no lung pulse, no B lines, no C lines, and you have a lung point, it's a pneumothorax, obviously. But if you have sliding which is present and if you have B lines, obviously it's an alveolar interstitial syndrome, or it can be a pneumonia. That depends on whether it is you have a unilateral pathology or a bilateral pathology, or you have to know whether there's a shred sign which is present or a dynamic air bronchograms which are present. But moving this is pretty well explained in the blue protocol. But moving to the right side, if you have a fluid interface, it can be a solid fluid interface in which you have a pneumonia, it may be atelectasis, or it may be a pulmonary infarction, one of these. And if you say liquid interface, obviously it's pleural effusion. It may be a transudative effusion, exudative effusion, it may be blood, depending on what you see in the fluid. So if the fluid is completely anechoic, without any planktons, it may be a transudate or exudate both. But if you have planktons and free floating particles in the fluid, or you have fibrin in the fluid, it may be exudate or blood. Fibrin goes more for blood. Okay, so this is how a multi-focused lung ultrasound algorithm goes. Now, again, you have one more protocol called as FALS, which is fluid administration limited by lung ultrasound. And FALS is nothing but a corollary of blue protocol. But in FALS, first you have to rule out an acute circulatory failure. So you do a cardiac ultrasound or an echocardiography eyeballing, in which you rule out an obstructive shock. So you rule out pulmonary embolism and cardiac tamponade or a pneumothorax first. Once that is ruled out or any obstructive shock is ruled out, you go to give fluids. Okay, so this is how we manage hemodynamics with FALS. So no obstructive shock, no pneumothorax, and if there is a profile, you keep on giving fluids in a hypotensive patient. Okay, so till there is clinical improvement. If there is no clinical improvement, you eventually get B lines and B lines are generated, but usually this is a septic shock because your heart is normal here. And if there is a clinical improvement here, that's a hypovolemic shock. But if after giving fluids, there is no clinical improvement and eventually your going to get B lines, that is generally a septic shock. So this is again, lung is an end organ, and when you get B lines, it is 100% positive predictive value for interstitial edema or fluid overload. Then you have pink clot or fever protocols. I won't go into details of this. You also have lung ultrasound for early diagnosis of ventilator-associated pneumonia. And moving on to the pleural effusions, this is a schematic diagram of how you get the pleural effusion. This is the bat wing, that's the parietal pleura, that's the chest wall, that's the visceral pleura. And you get the fluid in between the visceral pleura and the parietal pleura. So you are using the high frequency probes here. That's the chest wall, that's one rib, that's the superior rib, that's the inferior rib, that's your bat sign. Okay, that's the parietal pleura. And this anechoic space here is the pleural effusion. So you can quantitate what is the depth of the pleural effusion. So if I want to tap here, then I'll go at least 1 centimeter inside. The fluid is between 1 to 3 centimeters here. So I'm sure that I don't hit the lung and I don't go beyond 3 centimeters here. And you can do a real-time pleural tapping, or you can do a you can do a landmark technique also. You can see that consolidated lung down here. That's the parietal pleura. That's the visceral pleura, and that's the anechoic fluid which is there. Now, pleural effusion detection is pretty easy, and ultrasound is even more sensitive than the CT scan for picking up fluids. And as I said, interpleural distance is important. So you have a semi-quantitated method of quantitating how much fluid it is. So if it is more than 500 ml, then the distance between the fifth intercostal space is more than 50 millimeters, that is 5 centimeters. And if the end expiratory basal interpleural distance is more than 45, then it's around 800 ml. So these are different methods of calculating it. One of the methods which I had described earlier also is fluid quantitation by this. So this is the interpleural distance from the diaphragm, the pleural distance from the diaphragm and expiratory value. And if that is multiplied, that is the V, the separation is in millimeters, multiplied by 20 is the amount of fluid which you get. This was published in the Intensive Care Medicine in 2006. Okay, so if you have a separation of around 10 millimeters, it's 10 by 20, that is around 200 ml. If the separation is around 100 millimeters, that is 10 centimeters, then it becomes around 2 liters. Okay, so this is how you calculate the fluids quantitatively. So these are few things. And of course, you can differentiate effusion with consolidation very nicely. Sometimes the X-rays can be obviously misleading. And on the left side, you can see that again, there is a haziness there, angle blunting is there. And again, on the right side here on the X-ray, you can see a similar picture here. But here you have a clear-cut fluid which is there, pleural effusion which is predominant. And here you have predominantly a consolidation, a Chiret sign there. The effusion is not significant there. So the accurate, how do you detect pleural effusion accurately? Sensitivity is as good as 92 to 93%. It also gives you the decision to perform thoracocentesis. Okay, ease and simplicity, and most importantly, once you tap, you can know that how much fluid you have withdrawn and what is the end result, and is the underlying lung which was collapsed has come up. So this is the criteria for safe thoracocentesis. The first and foremost is the effusion should be definitive. You have to have a chord sign and sinusoidal sign. Sinusoidal sign is nothing but the M mode on the chord, and you will get a lung which is moving up and down. That is called as a sinusoidal sign. Again, that's one of the confirmatory diagnosis for pleural effusion. Sometimes chord can be misleading. Okay, so the interpleural distance should be at least 15 millimeters at 3 adjacent intercostal spaces. That's very, very important. And you have to avoid other vital organs like the heart, liver, spleen apart from the lung itself. You have to go at the upper border of the lower rib. And in a static technique, the position and the respiratory variation should be noted. So if it is a very small effusion, then we have to be very careful about the respiratory variations if you are using your landmark technique. Okay. Now, this is one video where we had a patient with a CL lung. He had a small cell carcinoma, and he had a hazy right side on the X-ray. It was not very clear. He had a huge mass in the right side also, so we didn't know whether it was associated significant fluid or no. And you can see very nicely here, this is a consolidated lung jellyfish sign nicely seen. That's the diaphragm, right diaphragm. And you can see the liver here, and you can see those hypoechoic structures, rounded structures, those were liver metastasis also. And you can see some fibrin floating here. It's not a very clear fluid. So we went in and tapped him. We put in a pigtail catheter here. You can see the pigtail very nicely here. And this is when we put in the pigtail catheter, and we almost aspirated around a liter of blood. So it was a hemorrhagic fluid, not exactly blood, but it was a hemorrhagic fluid secondary to the metastasis. So it was a pleural involvement also. So you can see very nicely here. And obviously this was metastatic because you can see those hypoechoic structures in the liver here. If you can appreciate this here, this clip here, you can see those hypoechoic rounded structures in the liver. So whenever you're looking at a diaphragm, look subdiaphragmatically also, the liver on the right side, the kidney on the right side, the kidney and the spleen on the left side also. So next, let's come to the next patient, a 55-year-old male, no comorbidities, presented to the ED with sudden onset breathlessness, had restricted movements due to compressive lumbar myelopathy, was tachycardic, tachypneic, drowsy, not obeying simple commands, blood pressure of 70 systolic, again, shock state, 82% saturation despite supplemental oxygen. He collapsed in the ED, CPR was initiated. Patient was thrombolized with altiplase. We did a proper field protocol here. We got an ultrasound machine during the CPR itself, and he was thrombolized with altiplase, and return of spontaneous circulation was achieved in less than 7 minutes here. There was a stormy course in the ICU. He started responding after 25 days, discharge after 45 days, and the last follow-up was recently. So this was his echo picture. Okay, so huge RA-RV acute cor pulmonale with a McConnell sign. You can see that as a pre-wall hypokinesia, and the apex is hyperkinetic here. And this was his IVC, a big plethoric IVC here, more than 2.5 centimeters with no collapsibility. And of course, this was a tank. Now, this is important because this was a lung. So normally in a pulmonary embolism, you will get a dry profile, that is a profile. But here we could pick up the pulmonary infarct here. So this was a pulmonary infarct which could be seen here. Again, hanging. I don't know what's happening. Probably too many videos. Let me. I'll have to reboot again. Sorry for this. So this was a pulmonary infarct, okay? And you can see that there is a subpleural consolidation. There is a break in the pleura here. And these subpulmonic consolidations were very classically seen in COVID times also. So they were actual subpulmonic consolidation secondary to COVID pneumonia. But here, this is a pulmonary infarct. This is a non-infective thing. So pulmonary infarct also can look like a subpulmonic consolidation. One more example of a pulmonary infarct, but you have a wet lung here. You have a consolidated lung here with a pulmonary infarct here. Let's come to another case, 36-year-old female admitted for intestinal obstruction, diagnosed to have a CA sigmoid colon. Post hemicolectomy, had an uneventful course, discharged after 15 days, presented to ED again with sudden onset dyspnea at rest and shock state, desaturating, cold, clammy again, obeying commands but drowsy. So what next? So obviously the best modality will be an ultrasound, because you can't transfer these patients to the CT scanner if they are unstable. So we saw this. So a huge RA clot going into the RV, a mobile clot. The differential diagnosis were obviously vegetations and a tumor, but here you can see it's a freely mobile clot there, and it's not attached to the valve. So vegetations were ruled out, and a myxoma was also ruled out because it was not attached to the wall, the arterial wall. Okay, so this was again his pipes. Okay, his pipes showed a proximal IVC clot. Okay, which had come from the deep veins because of the thrombogenicity he had because of the infarct. Now moving to some other applications for lung ultrasound, you can very nicely figure out rib fractures with lung ultrasound, and this can be done in your emergency department for any patient with trauma. So this is how it goes. So that's the transversal view. So that's your rib, okay, and that's the break. Can you see this rib? And this is a rib acoustic shadow which you see in the bad sign. So that's the rib acoustic shadow, and that's the pleura there. So that's the rib here, okay. So I will show you a longitudinal picture here in which you can appreciate it. So you move the transducer from transversal position to the longitudinal position here. And now you can see very nicely the break in the rib. You can see that the cortical break is here. So again, move from the transverse position to the longitudinal position here. Okay, and you can see this break in the rib here. Okay, so you can see the fracture very nicely. So the same thing, so you have to palpate, you have to ask the patient where the maximum tenderness is, and keep your vascular probe, because rib is a superficial structure. So don't use your phased array probe here, use your vascular probe here, and go transversely as well as longitudinally, and then you can trace the fracture here. One more application is sternal fracture. So you have the ultrasound probe placed in the sagittal orientation on the sternum, and the probe is moved from cephalad to caudal. So that's the sternum. Okay, that's the normal suprasternal notch. Going down here, that's the sternal outline, and that's the manubrium. So this is not a fracture, that's the manubrium sternum. So don't mistake this as a fracture. That's the sternal angle. There's a smooth change in the direction, okay, when you approach the manubrium here and going down here. And you again go down further. You slide the ultrasound probe down further, and you can see the fracture then. Which again. I think there's some virus. So let's go to case 4, a 72-year-old male post-commando surgery for CA buccal mucosa, reintubated for type 2 respiratory failure. Immediately post-op day 0 was difficult to wean, no comorbidities. His metabolic weaning parameters were normal. His pre-op cardiac and lung function was absolutely normal. His pulmonary function test, which was done preoperatively, was also normal. Now, this, so what next? So what do you do? Why is there a weaning failure? So focus helps in weaning failure, and there's something called as a focus weaning protocol, in which you can use three things. One is the lung. So you see whether the lung is dry or wet, okay, and use the blue protocol in the lung. Then the second thing is the heart. That's you do a screening echocardiography and check out for the LV function. If the LV function is normal, you go for the E by E prime, you check out whether there is a diastolic dysfunction. So many a times you see that if the LV, even if the LV function was okay, many a times diastolic dysfunction is missed out on the pre-op echo. Not many people screen for diastolic dysfunction. So it's very important to do the E by E prime. If the E by E prime is less than anything less than 12 to 14, that's a normal diastolic function. But if the E by E prime is more than 14, that means there is significant diastolic dysfunction. And sometimes you may get diastolic dysfunction during weaning because ischemia may be precipitated during weaning, and weaning acts as a stress test for the patient itself. So there may be an occult coronary artery disease which is not picked up just on the echo, and the patient may not be symptomatic during that time, but the stress of the surgery or stress of the weaning itself puts you into a diastolic dysfunction. So that's the second thing which you do. And the third and the most important thing which many of us miss out is the diaphragm. So here we are going to talk about the diaphragm, and here is what we saw. So you can see the diaphragmatic ultrasound. That's the diaphragm. Okay, that's the right diaphragm here. Okay. And you can see that it is not moving that well. You can see eyeballing the excursions are less than 1 centimeter here. Okay, there's some amount of fluid up there. Okay, in the lung, pleural effusion. You can see one more picture here that the diaphragm is hardly moving. And this was on the TP, so we had put him on the TP. So many a times if the patient is on controlled ventilation or pressure support, you may not see the diaphragmatic dysfunction because it is ventilator assisted. But if you put them on TPs and you do the diaphragmatic ultrasound, or even with minimal pressure support, if you do the diaphragmatic ultrasound, these excursions can be seen very nicely that the diaphragm is hardly moving here. If you can appreciate this diaphragm here, that's the right diaphragm, that's the liver here. So weaning from mechanical ventilation, ultimately, if you go back to your basics, which I told you, the key role of load capacity balance is there. So you have the load, which is a respiratory system mechanics, whereas the capacity is the respiratory muscle itself. So if it is well balanced, the load and the capacity is well balanced, then weaning is possible. But if there is a problem, imbalance in the load and the capacity, then obviously you get an imbalance and these patients require mechanical ventilation. So diaphragm is the most important muscle and the most primary muscle of respiration. Okay. And if that has a problem, then obviously your weaning can be prolonged. So these are the time points when you intubate the patient is breathing spontaneously, you intubate the patient in the ICU, you give them controlled mechanical ventilation, you sedate them, you paralyze them initially. Sometimes they require paralysis or sedation for a longer time if they are if they have a primary problem which is not well controlled. And you then switch to partial mode of assistance, that is, you put them on pressure support for a weaning trial, okay, and see how they are breathing. So diaphragm ICU acquired diaphragmatic weakness is not because of a single parameter. It may be because of sepsis, it may be because of SIRS, it may be because of mechanical ventilation itself, it may be because of your neuromuscular blockading agents, your sedation, which is and of course the other things like infections, hyperglycemia, steroids, and all those which cause critical care polymyoneuropathy. So it's a multifocal thing, but can we anticipate problems in those patients who are difficult to wean? And the answer is yes. And that is why your diaphragmatic ultrasound is very, very important. It can be used for diagnosis of diaphragmatic paralysis and recovery. Okay, very important. Previously, in the older generations, when we didn't have ultrasound, we used to use fluoroscopy. I don't know how many of you have seen a fluoroscope, but we have seen our fluoroscope, and that time we didn't have anything but a fluoroscope to know how the diaphragm was moving. We used to take them down to the fluoroscopy department and do a sniff test to know whether the diaphragm was paralyzed or no. So if you ask them to sniff, ask the patient to sniff, and the diaphragm is moving up instead of moving down, there is a paradoxical movement, and that indicates that there is a diaphragmatic paralysis. Now, diaphragmatic ultrasound has revolutionized that thing. So it serves as a bedside screening test for investigating postoperative diaphragmatic dysfunction. It detects synchronization of spontaneous breathing efforts with the ventilator and potentially allowing an optimal adjustment of the ventilator settings. So it helps you to optimize your ventilator settings also. So what is the scope? Abnormal diaphragmatic movements can be seen in phrenic nerve injuries, neuromuscular diseases, post-abdominal wall or cardiac surgeries, critically ill patients on mechanical ventilation. So all these are indications for doing a diaphragmatic ultrasound. How do you do it? The probe is placed immediately below the right or the left costal margin in the mid-clavicular line. And you have to use the phased array probe or your curvilinear probe, because diaphragm is a deeper structure. Okay, or you can also keep the probe in the right or the left anterior axillary line. Okay, so the probe which is kept in the right or the left anterior axillary line is for zone of opposition. So there are two things which you have to evaluate when you are evaluating diaphragmatic function. One is the excursion, the movement up and down of the diaphragm with respiration, and second is the thickening of the diaphragm. Okay, so these are the two things which you evaluate. Now the ultrasound beam should reach perpendicularly to the posterior third, okay, of the corresponding hemidiaphragm. And the two-dimensional 2D mode is initially used to obtain the best approach, and then the M mode is used. So what is the gold standard for assessing the diaphragm? Okay, the gold standard for assessing the diaphragm is phrenic nerve stimulation with a magnet. Okay, you use a magnetic stimulation for the phrenic nerve in the neck, and you check out on the tracheal pressure. So you make them breathe spontaneously, take the ventilator off, and stimulate the phrenic nerve with this magnetic stimulation in the neck. Okay. So when you stimulate the phrenic nerve, obviously there will be an inspiration, there will be an inspiratory effort. If that inspiratory effort is more than negative of 30, then it's a significant, that means the diaphragm, there is no diaphragmatic dysfunction. But if that inspiratory effort is less than 10, that means there is some problem, or less than 15, that means there is problem. But this is very cumbersome to do and practically not feasible, though this is a gold standard. So this is used in studies to compare the diaphragmatic ultrasound along with this. And they found out that diaphragmatic ultrasound, especially the thickening fraction of the diaphragm, correlates very nicely with the gold standard. Okay, so this is how it goes. Now, this is what we see, diaphragm weakness to predict failure. This is the anterior approach, okay, where you see the thickness, where you see the excursion. You keep the probe in the mid-axillary, mid-clavicular line and check out the excursion of the diaphragm. And for the intercostal view, you have to use the vascular probe, because for diaphragmatic thickness, you have to check out, insonate the zone of opposition. I'll come to that. And for that, you require a superficial probe. Okay, so two probes will be required, the phased array and the superficial probe. And this is what we see. The anterior subcostal view, you see the the excursion, whereas the zone of opposition is to be seen in the anterior axillary line, okay, in the 7th to 9th intercostal space. So this is a schematic diagram where you keep your probe, okay, the phased array probe here. The phased array probe is to be kept in the mid-clavicular line, that is for excursion. And this is how your beam goes. So it insonates the diaphragm at the dome here, okay, at the height posterolaterally here. So this is how you insonate. Again, this is one more schematic diagram in which you see this is the probe, that's the beam, okay, and this is how you see on the M mode. So there will be excursion like this here. So this is a schematic diagram, again a still image here. So that's the selected M mode here, that's the diaphragm mode. I put the M mode on here, and with inspiration the diaphragm is going to move down, and this is how you see the excursion will be seen positively, and during expiration it will come down again. So this is end of expiration, and this point is the end of inspiration. So your highest excursion will be during the end of inspiration, and that is your diaphragmatic excursion. So this diaphragmatic excursion should be normally in a normally breathing patient more than 1 centimeter. If it is anything less than 1 centimeter, that means there is a problem. But you have to check it in 3 parameters. One is quiet breathing. Second is voluntary sniff. Ask the patient to sniff. That's a sniff. Ask the patient to sniff. And third is deep breathing. So normally, whenever you want to check out on diaphragmatic paralysis, you ask the patient to sniff. On a sniff test, if the diaphragm is moving paradoxically, that means there is a diaphragmatic paralysis. But very rarely you can have paralysis. Of course, post CABG, we have seen paralysis. We have seen other traumatic diaphragmatic involvements also in which there is paralysis, or phrenic nerve injuries in which there is paralysis. But more common is diaphragmatic paresis. And for that, quiet breathing is good enough. If the patient is on the ventilator, you have to temporarily disconnect the patient from the ventilator and do the insonation for the excursion. If it is less than 1 centimeter, that means there is something wrong. That means there is definite diaphragmatic paresis. So There are different criteria for deep breathing. In deep breathing, the excursion should be at least 6 to 7. Okay. Lower limit is around 3.7 for women and 4.7 for men. For a sniff, it is around anywhere between 1.6 to 1.8. Okay. Now this is how it looks. So this is the diaphragmatic excursion, and this is the M mode. I have cut it perpendicularly like this. So you have to make sure that your M mode is cut perpendicularly. If you don't cut it perpendicularly, your readings may be wrong. Okay, and this is how the diaphragm looks. That's the diaphragm, pearly white structure there. Okay, and down below is the liver on the right side. So this is the eyeballing. The same patient again on TPs, and it's the diaphragm is hardly moving, less than 1 centimeter movement is there. So just eyeballing tells you that this diaphragm is not normal. The excursions are less than 1 centimeter. Now let's come to the diaphragmatic thickness. Now, what is the zone of opposition? The zone of opposition is the diaphragmatic layer which is in the transition of the lung and the abdomen. So there will be a diaphragmatic pleura which goes down, and there will be a peritoneum which comes up from the abdomen. And this is where the zone of opposition is. It is high in muscular tissue, mostly rectilinear, and it is parallel to the rib cage. So that the red color code is your zone of opposition, whereas the dome it has a low content of muscular tissue. So that dome shape is perpendicular to the rib cage. So this is zone of opposition. One more diagram here. That's the parietal peritoneum. That's the pleura, okay, which is there. And in between is your zone of opposition here. So that zone of opposition is used for knowing the thickness of the diaphragm. Now this is again the excursion, but this is the thickness. I'll come to one more slide which is there. Now you can see here, this is for the excursion. Okay, that's the diaphragmatic excursion during quiet breathing. And you can see during deep breathing, it's almost 7.3. So this is a normal diaphragm. So this diaphragmatic excursion is normal. Now, they have done a study which said that the diaphragmatic function had switched from assist control to pressure support, and it predicted the outcomes of diaphragmatic paralysis or weaning. So if the diaphragm dysfunction was present, which was defined as the thickness fraction less than 29 or less than 30, that means these patients required a prolonged time for ventilation. And how do you do the thickness fraction? I will come to that again. Now, extra diaphragmatic muscles are also scalene and intercostal muscles. They are also equally important. And there are studies of scalene and intercostal muscle ultrasound also. So whenever the diaphragm is failing, these scalene and the intercostal muscles take over, and they hyperfunction. Okay. So whenever your diaphragm is failing, then you get, these are not the accessory muscles. Scalene and intercostals are actually the primary muscles along with the diaphragm, but they start hyperfunctioning whenever your diaphragm is failing. And there are studies of scalene and intercostal muscle diaphragm insonation by ultrasound also. And that's also interesting, not in the purview right now here. So this study was done in post cardiac surgery patients. And in cardiac surgery patients also, you may have a significant amount of diaphragmatic dysfunction here. And what they said is that if there is no active caudal movement of the diaphragm, obviously it's a paralyzed diaphragm. But more commonly, you get a paretic diaphragm. Now, this is a conclusion which you make from the M mode. Okay, so M mode is relatively simple and accurate for diagnosing the paralysis of the diaphragm. And the thickening fraction is important. Now, the thickening fraction is nothing but, I'll go 1 minute. So this is it. So you can see the slide. So you go on the zone of opposition with the vascular probe. You can see 3 layers. That's the upper layer is the pleural layer. The lower layer is the peritoneum layer, and the middle layer is the diaphragm actual muscle there. Okay. So whenever the patient inspires, there is a thickening of this aponeurosis. So the diaphragm will thicken during inspiration, and you check out the thickening fraction. Thickening fraction is nothing but the end expiratory value of the point of the zone of opposition minus the end inspiratory value. Okay, and that is divided by the end inspiratory value again. So that is the thickening fraction, and if that thickening fraction should be more than 30. If your thickening fraction is less than 30, that means there is a reduced thickening, and that is more reproducible as compared to the excursion. Excursion may not be as reproducible. Now you can see this again slide here. These are the three layers you can see. Okay, this is the pleural layer. In between is the actual diaphragmatic layer, and that's the peritoneal layer. And so when you ask the patient to inspire, there'll obviously be a thickening of the diaphragm during inspiration. And this is how you calculate the thickening fraction. Thickness at the end inspiration minus thickening at the end expiration divided by the thickness at the end expiration again. And this was published in ICM in 2013. So diaphragm is very, very important, and it is a whole topic by itself. So all of you, diaphragmatic ultrasound is very, very easy. So in one, maybe if we can take a proper hands-on session for a diaphragmatic ultrasound itself, and that makes life very easy. So currently we are in the midst of a study of weaning, ultrasound guided weaning, in which we are including the diaphragm also. Now, the next topic is COVID. Okay, so this is our paper. So I proudly present this paper. We published this paper in European Journal of Radiology in November 2022. And this was in COVID-19, during COVID-19 pandemic, utility and diagnostic tests and properties of pulmonary and cardiovascular point of care ultrasound. And we had almost 200 patients during that time. We completed almost more than 1,000 patients with diaphragmatic with COVID-19 protocols. And this is what we did. All the patients with moderate to severe symptoms are screened with Muse2 score. Okay, lung ultrasound with a modified blue protocol was done. It included also the cardiac ultrasound, which included the screening of the heart, no fancy measurement. And last but not the least was venous analysis. Because COVID is a multi-system disease, we included everything. And all the organs were involved, not only the lung, but it was not like H1N1, which only included the lung. It included the heart, included the brain, it included the endothelium, it included the great vessels, everything, you name it, and all the organs were involved. Okay, so we repeated it in every shift, and the complete screening was done in less than 10 minutes. So this was one of the lung ultrasound which we got. Classical, can you see the subpulmonic consolidation, irregular pleura, thickened pleura, and B lines there. So this is classical interstitial pneumonia with COVID. Again, B prime profile or a B dash profile, predominantly posterior basal. Okay, and this is what we saw on the screening of the deep vein. So what we saw was that we didn't see too many thrombosis. Our thrombosis incidence was almost 5%, but maybe because we were insonating the patients too early when they came to the ICU immediately. And we started them on prophylaxis and treated them also. But what we found out interestingly was that there was a slow flow. I'm sorry that this video is not working, but there was a complete compressibility of the common femoral vein and the popliteal vein, but we could see spontaneous echo contrast, hazy thing, okay, hazy shadows, okay, hyperechoic shadows. And then we went through the literature in Cleveland Clinic Intensive Care. They had published this, in which the deep vein thrombosis, that is the spontaneous echo contrast, not the deep vein thrombosis, were as high as 25 to 30%. And then we started doing it in our patients also, and we found out that the spontaneous echo contrasts were as high as 60 to 65%. Okay, so that was significant. And these were the patient groups in which we gave them therapeutic anticoagulation. Of course, later on it was proven that it may not be required. The therapeutic anticoagulation was not required for these patients, but that was the initial part of the pandemic. So this was an eye-opener for us, and we did very well with the COVID-19 protocol with ultrasound. We avoided a lot of unwanted CT scans. People used to do 5 CT scans in a single patient in a span of 5 days. Okay, so that was avoided. The radiation was avoided, and we could pick up a lot of things, pneumothoraxis, okay, a lot of things, except for a few patients who had subcutaneous emphysema because of pneumothoraxis. We could insonate most of the patients. Now coming to one more application, advanced application, is aeration deaeration score. Okay, so this was used in COVID also when we were ventilating COVID ARDSs, but this was described before COVID also. So what you do is you initially insonate the lung. Okay, before recruitment maneuvers or before proning them and see the lung ultrasound score. So this is a normal lung, which is a A profile. Then you can have non-coalescent B line. Then you have coalescent B lines as the consolidation increases or ARDS progresses. And then you have lobar involvement, the complete lobe which is involved, and subpleural involvement. So that's the loss of aeration. So if you go from here, which is a normal lung, to here, that's the loss of aeration. And from the left side to the right side is best aeration. Okay. So obviously you don't opt for a hyperinflated state, but this is what you get. And this is a lung ultrasound score. So lung ultrasound score of 0 is normally aerated lung. That is the A profile. If it is 1, then you have multiple non-coalescent B lines here. If it is 2, then there is severe loss of aeration and you have multiple coalescing B lines. And if it is 3, then it is lobar consolidation. Okay, so if you are doing a recruitment maneuver, you have to go from this D to A profile, or LUS of 3 to 0. That means it is good recruitment. Or even if you go from LUS of 3 to 1, it is a good recruitment. So that can be used as a therapeutic marker for your recruitment maneuvers or proning. Okay, proning is obviously like a recruitment maneuver. So this was seen here. So with that, I end here. Sorry for the delays in because of the technical errors, but I'm open for questions here.
Thank you very much, sir. Thanks for this wonderful and very informative session on the lung ultrasound. And this part was really not well understood by many clinicians and intensivists. You made it so easy to understand the topic very well. Can we take few questions? There are a few questions in the chat box.
Yeah,
And
sure. So what feature you see in fractures? So in fractures, you see a break in the cortex. The cortex is pearly white hyperechoic structure. Okay. So if there's a rib fracture in trauma, sometimes the X-rays may not pick it up. So wherever there is maximum tenderness, we take the vascular probe. Why vascular probe? Because it is superficial. The rib is superficial structure. So in vascular probe, the superficial structures are best seen. And first we go in a transversal approach. With the transversal approach, you delineate the rib. Okay. And then move the probe 90 degrees in a longitudinal approach. And in the longitudinal approach, you can actually trace the rib from posterior to anterior area. Okay. And then you can see the break in the cortex. So if there is a break in the cortex, then it means that there is a fracture. And fractures, the sensitivity, specificity in fractures is very good. Whether it is a rib fracture or a sternal fracture or long bone fractures, also you can use this insonation technique. In bullous lung over bulla, do we see absent sliding or barcode sign? Yeah. So a good question here. So in the bullous lung, see, when do you get absence of sliding? So whenever why do you get sliding? You have to know why do you get sliding. So you get sliding because the pleural fluid, which is a viscoelastic fluid, okay, which has viscoelastic properties, is replaced by air in a pneumothorax, okay. But in a bullous lung, the sliding will be absent because of that bulla, which is just subpleural. You will see an absent sliding, and you will also get a stratosphere sign. But the difference between a bulla and a pneumothorax, a big bulla and a pneumothorax, will be that there will be a lung point in the pneumothorax, whereas in the bulla, you won't get a lung point. Now, sometimes it becomes very, very difficult to differentiate between a bulla and a loculated pneumothorax. So there you may have to do a CT scan, but you have to use your clinical parameters. Suppose you have put in a central line and preoperatively there was sliding present, and now you have absent sliding, and even if you're not getting a lung point, you can still put a ICD because there is no other differential diagnosis. Does that answer your question? Okay.
there is one more question pertaining to
Diaphragmatic evaluation,
videos.
where to see videos. Okay. There are very good videos on the net itself. Okay. So you can see those videos there. And what I'll suggest is that diaphragm is very easy to do. There are, again, simplifying diaphragm. There are two things you have to see in the diaphragm. One is the excursion of the diaphragm, in which you use the phased array probe or your curvilinear probe, okay, in the mid clavicular line, and insonate the diaphragm to see the excursion. Put it on the M mode to see how much excursion is it. If the excursion is less than 1 centimeter in a normally breathing patient, that means that there is a problem. Okay. Now you can use it in a sniff position and a deep breath also to complete the examination. And the second thing is zone of apposition, where you evaluate the diaphragmatic thickness. That is very, very important. The zone of apposition uh, on landmark technique is anywhere between the seventh and the ninth uh, uh, intercostal space in the mid-axillary line, okay, just below the phrenic point. And there you see the three layers. Here you have to use a vascular probe. There you see the three layers, the pleural layer, the peritoneal layer, and the actual diaphragmatic layer. And ask the patient to inspire, there will be a thickening of that zone of apposition. And then you have to calculate the thickening fraction, which I told you. If the thickening fraction is less than 30%, that means definitely there is a problem. That means that definitely there is a diaphragmatic dysfunction. Now here, this thickening fraction is more reproducible as compared to the excursion. So you have to combine both. Where to see the videos? Yes, there are a lot of videos on diaphragmatic ultrasound on the net. You can get it. If you want any specific references, I can forward it to Akhilesh or Gunadhar. They can forward it to you. I think the
Yes, yes,
next
sure,
question
sure.
is differentiating between pulmonary edema and pneumonia on lung ultrasound. Okay, fine. So if you go back to the blue protocol, then I'll just go back to the blue protocol. Yeah. One minute. So can you see the slide here?
No, no,
So,
slide is not. You have to share the screen.
okay, so I will tell. So in pulmonary edema, you will get a pulmonary edema can be of two types. One is cardiogenic edema and second is non-cardiogenic, which is ARDS. Now, pneumonia can be focal. Okay, pneumonia can present as uh, either a shred sign or a tissue-like sign or subpulmonic consolidation. It can be multifocal also, as in bronchopneumonia, both bilaterally. But there you will get a proper shred sign or a tissue-like sign or a subpulmonic consolidation. Whereas in pulmonary edema, you will get B lines which are more uniform, okay, which are bilaterally symmetrical in cardiogenic edema, and the sliding is present, and the sliding is not and the pleura is not thickened, it is regular. Whereas in ARDS, you will again get bilateral B lines. They are non-homogeneous. Okay, like in cardiogenic edema, they are not like cardiogenic edema. They are non-homogeneous, non-uniform. Sliding may or may not be present, and the pleura will be slightly irregular in ARDS. You can get subpulmonic consolidation in ARDS. The classical example of ARDS on the lung ultrasound is COVID pneumonia. So this is how you differentiate between pneumonia and ARDS and pulmonary edema. Now, in pneumonia, you can get dynamic air bronchograms. So if you get dynamic air bronchograms, which I showed you, that's a hallmark of consolidation, and it is not ARDS.
Yes, that's pretty clear actually. Though it has a learning curve, but when we do it regularly in our bedside rounds, probably everyone will be able to appreciate the abnormalities very well because this has a learning curve. So, sir, I mean, how do we differentiate different entities? Like in COPD, will we be able to differentiate, like, the lung is overinflated, and at times it is very difficult to get the images also. So, how do we solve that problem, and how do we get through that?
So COPD basically will be a diagnosis of exclusion. So if you go to the blue protocol, the first thing will be lung sliding. So sliding will be present in COPD. And in COPD, it will be a null profile. Initially, you'll get a profile. Okay, so you'll get parallel lines. Okay, and in the venous analysis, the veins will be clear. And even on the prone ultrasound, even on the prone points, or even on your zone 5 and 6, there won't be any B lines at all. It will be a profile all throughout. Okay, so basically, and the heart will be normal, so there won't be any cardiogenic element. Of course, if there is an associated cardiac problem with the COPD, the heart may be abnormal. But if you just take the blue protocol, then you get lung sliding, you get a profile, the venous analysis is negative, the PLAPS is negative for pneumonia, and there are no B lines. So that is how you come to a conclusion that is COPD or asthma. But your preclinical probability and your examination and history is also important here.
Thank you, sir. Thank you for the excellent presentation. So I just request all the participants, they can refer to your previous lecture, which is there on the YouTube for the basic ultrasound, which is very, very important. I think you have made the basic understanding absolutely clear, crystal clear, I can say. Then with the advanced ultrasound, the knowledge will be complete. One question from my side, sir. We have one patient on ECMO who has a lung fibrosis. So how does the ultrasound help in such cases in winning your maintenance or your troubleshooting in the ECMO machine, sir?
Yeah, so as I said, ultrasound weaning protocol consists of three basic parts. One is the lung. So here, if you have post COVID fibrosis or post infective fibrosis, you will get a B prime protocol, B prime profile. That is, there will be break in the pleura. There will be the pleura won't be irregular, and you will get inhomogeneous B lines. So, but here, what you see is whether there's any shred sign, or whether there are any dynamic air bronchogram, or whether there's any significant fluid in the lung, which is important for weaning. So if that is there, then you can treat it. That's one in the lung. So you see the tank, how the tank is. The most important thing is diaphragmatic dysfunction. Okay, but before the diaphragm, you check for the heart. If there is any systolic dysfunction, if no systolic dysfunction, check for diastolic dysfunction. That's also important, because on the ECMO also you can get diastolic dysfunction. Patients with long-standing ECMO, you can get diastolic dysfunction. That is predominantly missed on weaning, not conventional weaning. And last but not the least is diaphragm. Invariably, when the patient is ventilated for so long and is critically ill, you have some amount of diaphragmatic dysfunction. So you have to check for the excursion and the thickening fraction here. So all the three clubbed together. Of course, the IVC has to be seen along with the heart. So all the three clubbed together. So fibrosis, it gives you an idea about the extent of the lung injury. So how bad is the lung ultrasound score, whether the lung is recruitable or not recruitable, or whether it is end-stage fibrosis in which you can't do anything. So this is how it helps. So your lung aeration deaeration score also comes into picture here.
And can we have a prediction score that we can, at least with some predictability, we can say that this gentleman is, the lungs are not going to recover so fast, or it is he has landed up in irreversible lung disease, because now this patient is on almost on 60 day on this thing on ventilator with 10 days of ECMO. His lungs are still bad. It is stiff. So any such prediction model can we, sir, formulate?
Yeah, so in COVID also, we had a lung ultrasound score, and our cutoff was around 18 for a very bad lung, 18 to 20. So you have different prediction models in lung ultrasound, not only for COVID, but non-COVID cases also in ARDS, in which the higher the score, poorer is the prognosis, and more chances that they may go into a fibrotic stage as compared to coming out of the ventilator. So it's not just the lung ultrasound here, but it will be a combination of factors. Lung ultrasound will aid in giving you the severity of the lung ultrasound score.
Okay, sir.
Yeah.
Sir, I think there is no more questions. So,
Okay.
so I think we'll let's wind up the session. And it's definitely we appreciate your efforts, and thank you very much for being with us for today's session. And thank you to all the participants from our side, Critical Care Department, Apollo Hospital, Navi Mumbai. And thank you, sir, once again, sir.
Yeah,
And
thanks
we'll,
for the invitation, and sorry for the technical glitch. We lost some time in that. Thank you.
no issue, no issue. And we'd like to have more such interactive session
Yeah,
with you
yeah,
also, because the experts are, it will definitely help our students. Thank you, sir.
yeah.
Thanks.
Okay, thanks. Thank you.